Happy and Healthy, a series to help you learn about available resources.
Welcome to another edition of Happy and Healthy. This is a series that is aimed at helping seniors, older adults, and their families know about the resources available to them locally. Today we're going to be talking about identifying mental health issues for adults and seniors. And we have with us Leslie Killey, who is a doctor and director of Trauma Recovery Services at the Crisis Center of Tampa Bay. Welcome, glad you could be here. Dr. Victor Molinari, who is a professor at USF School of Aging Studies, thank you. And Dave Kershaw, who is a PhD director of acute care services at Northside Mental Health Center. So welcome to all of you, and we're gonna get into this topic in a minute, but first I'd like to ask you to tell us something about the agency that you represent, the Crisis Center. Leslie, if you talk about what it's about for the people who don't know.
Sure. The Crisis Center, we're a nonprofit, Crisis Center at Tampa Bay. We've been around this year for 40 years, and we have 211, and we have sexual assault services. I think for this show, the most important one is we have an elderly reassurance line where we call 300 people who are socially isolated, living at home, daily if needed, every single week. We get to touch their lives.
That's great.
At the University of South Florida School of Aging, and basically it's part of the College of Behavioral and Community Sciences. And what we do are two major things. First off, we do applied research. A number of us do mental health research to hopefully further the knowledge base regarding mental health problems of older adults. And then the second thing is that we teach aging courses to undergraduate students, master's level students, and we have a doctoral program in aging studies.
How long has that been there, the aging program? Do you know?
Boy, the master's program is one of the oldest in the country. I believe it's been in existence for over 30 years. The doctoral program certainly has been around for 10 years or so, and it's one of the few doctoral programs in aging studies in the country.
Great, thank you. Dave, talk about Northside.
Yeah, Northside Mental Health Center is a not-for-profit community mental health center here in North Tampa. We were founded in the mid-'70s, and we're a comprehensive behavioral health service provider. So we provide interventions over the entire lifespan. So we have programs for children, for adults, and for older adults. And really the services range from simple medication management, you come in and you see the psychiatrist once every 3 months or so, to more intensive services, including residential programs as well.
Great. Well, let's get right into this. So there are things we understand are peculiar to the aging population in terms of mental health issues, and I thought, let me open this up and we can just talk about that. I've heard about suicide, I've heard about depression. Vic, you're the guy doing the studies. Let me ask you.
Well, there's a couple of things. First off, I think we should recognize the overall context, and that is that older adults in general are just as satisfied with their lives, perhaps even more satisfied than younger adults are. However, we also recognize that there are certain peculiar challenges for older adults, that is, losses relating to relationships or retirement or particularly disability, that can cause depression. Depression is the most common late onset problem of older adults, And as we talked about earlier in the meeting room, older adults who are males over the age of 75 who are isolated and who have no religious affiliation are by far and away the highest suicide risk of any age group. So there's a double-edged sword there. Most older adults are doing reasonably well. However, when they do show symptoms of depression, we should take it seriously and not think that this is just typical of older adults. It's not, and it can be serious.
Dave, could you address the difference between what we know to be just plain ordinary sadness and what clinical depression might be like?
Yeah, sure. Say, for example, the comparison between a grief reaction and depression. As people become older, they're going to have losses, and it may be a loss of a loved one. It could be a loss of a job if they're retiring. And oftentimes that grief process is going to include some symptoms that are like depression. So sadness and thinking about the person or the loss, maybe some sleep disturbance. But those individuals are still going to have periods of time when they're not feeling depressed, when it's capable for them to find pleasure in something that they're doing. They are not going to be obsessed or having ruminative thinking that they just can't get rid of about their depressive state. And so that's kind of the difference. When people become clinically depressed, you don't have these periods of time when things are still relatively normal. So there's a chronicity and a severity when someone becomes very depressed, and that really starts interfering with their function. People who are grieving still are able to kind of do what they need to do during the day, and they don't have the functional impairment that you may have when someone becomes very clinically depressed.
Leslie, is there a time frame on if you're looking at somebody who is sad and doesn't seem to be getting out of it, is like, well, they can only be sad for a few weeks, and beyond that, then we're going to worry that they're clinically depressed and we should take them somewhere?
Well, I think one of the blessings to remember is that grief is not on a timeline, that we can, a moment after cumulative loss, a year later, feel the power or that kick in the stomach of losing people. And a lot of the issue is anything like over, I would say, 2 weeks, 4 weeks with severe symptoms. You can read what a book will tell you, but if you're still not sleeping and that person may not be eating and they're not calling anyone, they're not reaching out to talk to anyone, they're socially isolated, or someone may start drinking to mask the pain, to mask the symptoms, and it doesn't help that many of our local liquor stores also deliver to people that we call elder, and in Florida, that's us, any of us over 50. So that's a huge, huge age group to call elder. But I think one of the ways to look at it for depression is imagine that you're numb. And I think one of the best books I ever saw was Sometimes My Heart Goes Numb, because when you get to be elder or older adult, what ends up happening, it isn't one loss we're experiencing, it's cumulative loss. It's our children are up north, and maybe if we've even met our great-grandchildren, they're somewhere over in Texas or in Colorado. There's just so many factors that are impinging on people in our community that are elder and coping with overwhelming feelings of sadness, anger, fear, distress, which all gets couched under this one word called depression.
And I noticed with my mom and other people as they aged, taking away the car keys. Huge. That is a really big deal. I mean, just stopping the loss of mobility, is that what you'd call it? It's just really an awful thing, too. You talked a minute, Vic, about suicide. What kind of signs should we be looking for if our parent or an elderly neighbor or something could be suicidal? And, we may have missed that. We didn't know or something. We've seen that before in our lives where someone we know did commit suicide. For some reason, we never noticed that they were that sad.
Well, I mean, for one thing, obviously, as was indicated, severe depression is probably the greatest risk factor for suicide. So if a person is severely depressed, that means that they're not eating and they're losing weight. they're not sleeping very well, they're having crying spells, they're very tired all the time, they're not involved in their typical activities. It's a time to worry if that goes over an extended period of time. But once an individual is preoccupied and talking about death and dying, and if they actually will say, I'm better off dead, that's called passive suicidal ideation, that should get everyone's concern. And the fact is that, as I understand, the research indicates that although many more younger adults actually will say that they're going to kill themselves but don't, older adults, if they say they're going to do it and they try to do it, they use more lethal methods. So once again,
they're not as unsuccessful, would you say? Is that what you mean?
I would say that they're more serious, and it's something, just as with younger adults, what we need to do is take these kinds of concerns into consideration and immediately get some kind of help for a person who is talking suicide or who has been severely depressed for a while.
You know, I have read where somebody jumped off the Skyway or something like, and then they go back and they do a story, and the people around them didn't know. They're completely oblivious to that. Like, how did that happen? You know, he was going to go to the prom or whatever it is. He was going to do something, and it sounded perfectly fine, or I would have gone to get help. Is there something about that I'm missing that sometimes you just don't get?
And I think with older people, particularly when they begin to become withdrawn and homebound, you really do have to take some initiative as a friend, as a relative, as a neighbor, to reach out and to ask those questions. I mean, I think it's a myth that you know, you talk to someone about suicide, you're going to give them the idea. That's not it at all. I should caution people, though, that oftentimes older adults who are experiencing depression won't manifest the symptoms or won't report the symptoms in the same way that a younger person might. For example, a younger person might use the word depressed. Right. If you ask an older person, are you depressed? They'll say, no, I'm not depressed. But then you ask them, what are they doing during the day? And they're not doing anything. They're calling the liquor store and getting alcohol delivered, which is a huge risk factor for suicide, by the way, substance abuse in general. That, you know, those are things that we need to be concerned about. If you see things like people making what are called kind of final acts, you know, they're calling people they haven't called for a long time, and they're thanking them for things, or they're touching base. They're getting their paperwork in order, for example. These are serious risk factors.
They're giving away things.
They're giving away things. They're saying, hey, can you take care of my dog? I may be going away for a while, or I'm going to take a trip or something. These are things that should give someone pause and dig a little bit deeper. You know, as far as the substance abuse issues, kind of a hidden epidemic in older folks. I was actually shocked to learn that we actually have liquor stores that deliver. You know, I thought that was only on college campuses, but no. And you know, when you're under the influence, you do things that you may not do when you're sober. But also, alcohol is a depressant, and it just kind of it's a vicious cycle in terms of some of the ruminative thinking and the negative thoughts that you have about your life.
Leslie, the crisis center takes suicide calls, right? Isn't that where they're
Absolutely.
sent over to?
211 is 24/7.
211, which a lot of people don't know. Just dial 211
Just dial
and get
211.
help.
Yep.
For many things, not just suicide, but
For any issue whatsoever, information and referral, or if you're feeling sad, or if you're at a place where you're ready to reach out for help, they can hook you in with trauma recovery services, which we have, or with Northside Mental Health or mental health care. There's also counseling services available there.
What do you hear when you get those calls? I mean, what are you hearing? Some of the things that Vic and Dave just mentioned, or other beyond that?
Well, absolutely, but I think a lot of it is what you don't hear.
Yeah.
Okay.
And what you don't hear is a strong voice. You hear somebody typically with some wavering speech, or they'll call and someone will ask for help and then they'll be silent. And it's almost like you have to push the conversation a little bit on the other end of the phone. Are you okay? Where are you right now? Trying to find out, are they living alone? Do they have an animal? Or is the person that's keeping them most connected right now the dog next door? Whether they're mad at the barking or whether they watch the dog take their morning walk, that may be their one connection to what's going on in life around them. When's the last time they talked to someone? Do they have someone that they call friend or family that they connect with? And that's a lot of the things we're trying to find out when we have someone on the phone is who is out there that's checking in on you.
What could they expect if they call any of you? Well, they wouldn't be calling you as a center, but your two agencies. So if they called and said, "Hey, I'm done with life and I'm just signing off," or however they put it, what happens next so that folks, viewers who are watching this and maybe somewhat reluctant to call will find out what they can expect to happen?
A lot of times what we will do is we will try to see if there's anyone close by or nearby, or even a family member that's out of state, that they will give us permission to call, and we can do a three-way call then and get them connected to see if they're going to be safe. And then obviously if they're not safe, then we're going to have to get some external community assist to go out and visit them at their home, or maybe just do a safe drive-by from one of our officers in the law enforcement field, just to make sure that they're safe and they're okay.
Okay.
And we've got teams available through such programs. You want to talk about that, Dr. Dave?
Yeah, and many times it'll be a family member who's actually calling. And for many years, I ran the mobile crisis team here in Hillsborough County. And unfortunately, because of a kind of a problem with just seeking help and the stigma associated with asking for help and being depressed, it's oftentimes not the individual who's depressed who asks for help, but it's someone who's concerned, a neighbor, a family member. So we would get the call, and I'll give you that number. It's for the mobile crisis team here in Hillsborough County. There's two teams. One's run by mental health care, the other one's run by my agency, Northside Mental Health Center. And you can call 272-2958 and ask to make a mobile crisis referral. And all that person has to do is, I'm concerned about my neighbor, my mom, she's this old, she's withdrawn, I just haven't heard from her, she seems off, she's irritable, something's different, something's changed, she doesn't want to see my grandkid anymore. It may be something as minor as that. And by calling the mobile crisis team, you're actually going to send out someone who's usually a licensed mental health professional will go out, and they'll go out with maybe another person, and they'll get an opportunity to speak with that person and kind of do that assessment. Now, unfortunately, sometimes the results of that assessment means a hospitalization. If the risk is so great, if we believe that this person is in imminent danger of harming themselves or harming other people, there's this issue of murder-suicide that's out there as well. But we'll go ahead and we'll have that person go to the hospital against their will. Fortunately, a lot of times people will be willing to go to the hospital. There are some hospitals here who have kind of a geriatric specialty in terms of depression and suicide in the elderly, and we'll try to facilitate an admission to those hospitals. Sometimes it's just reaching out and trying to make the connection, but you have to provide a little bit of motive force sometimes because that's really lacking.
Victor?
Let me just mention that, get back a little bit to the suicidal concern. Some of the research suggests that I believe 70% of older adults who eventually kill themselves have seen a primary care physician within 1 month of their suicide. What that means is that one of the ways, in addition to the mental health units or the crisis hotline, what we need to do is educate primary care professionals who are the frontline people who need to be educated about depression and the possible signs. I suspect, as was indicated, that these older adults went to their primary care doctor but didn't say, "Doc, I'm depressed." And these physicians probably were not so attuned to the mental health issues.
Maybe they just said, "I'm not sleeping well."
Yeah, right.
And the doctor said, "Here's
Exactly.
here's a prescription for some sleep medicine."
Or they have some sort of a bodily complaint, a pain issue or something.
Easier to talk
So they
about.
did. So they don't think to say, "Well, is something on your mind?" Is that what you mean? They're not
Yes.
saying, "Hey, are you?"
Yes, and one of the problems is that with too great frequency, oftentimes the suicide is actually committed with the pills that the doctor has prescribed for the person who has gone for that visit. So we have to be, this has to be a societal kind of approach to try to educate older adults, their family members, medical people, that this is a concern that can be addressed.
Yeah, and unfortunately, as antidepressants have gotten much safer, the risk for a cardiac event, for example, by overdosing on some of the old school antidepressants is much less. And PCPs, primary care physicians, are pretty comfortable in prescribing the newer
Xanax
generation.
and all these things.
Yeah, well, that's an anti-anxiety drug, and that's another issue too. You know, that the number one drug of abuse for older folks isn't your narcotic pain pills like oxycodone and these things that we're reading about with the pill mills. It's their anti-anxiety agents like Xanax. I was reading something that 13 to 23% of all medications prescribed to older adults are these benzodiazepines, these Xanaxes, and of course they're addicting too, and they have an effect similar to alcohol. So if you're depressed and you start taking these things, there's this kind of vicious cycle.
And then if you're drinking too?
Absolutely.
So they wouldn't probably be going to the doctor to get these pills to harm themselves. They might be going because they have a problem, and then it gets worse, and they end up taking the pills. Am I reading that right?
Yeah,
Yeah, and
it's
I love
masking the
Vic's
symptom.
suggestion about educating primary care physicians to have it on the radar screen. And if it's
This has to be taught in medical school, correct?
And refer to crisis hotline, go ahead and refer to community mental health centers when these kinds of issues occur.
Because a lot of times the remedy for that clinical depression isn't just taking a pill. The pill may help with regulating the appetite and the sleep and increasing kind of mood, but oftentimes it's more an environmental change. It's more providing meaningful activities. It's having people reconnect with their natural support groups. And that's not going to happen in the primary care physician's office. And so when you have life enrichment programs and things that we do in Tampa, those are the type of things that are really going to be beneficial in helping someone kind of reframe and kind of redo their life in a way that's going to be more protective.
Well, some of the things you just suggested are milder than saying to an older person, as I tried to do with my mom after my brother died, which put her really in a tailspin, put us all in a tailspin. But you have to go see somebody. Well, you don't tell an 80-something-year-old Italian woman from, she's not going there. I mean, there's no way they're going to go there. But the way you just said it is, let me help you reconnect with your friends or whatever. That's another ballgame. Am I right about this? Still as a stigma for a lot of people to even just go speak to somebody or go to a group or whatever?
Yes. I really feel that that's one of the issues with particularly the very old, that they have that kind of situation where they believe that if you have a mental health issue, you're crazy, or something like that kind of
I once
stereotype.
asked a therapist that question, and what he said is, if you think you're crazy, you're not. And that made me feel much better.
But when older adults are really trying to, if you're trying to get somebody who's older into go to get their mental health problems addressed, what you want to do is maybe work with a primary care physician who they have a relationship with, who they feel like they're more comfortable with, and maybe you could take the primary care physician aside and say, look, this is something that I'm concerned about with my mother. Maybe go ahead and check with her about how she's feeling. And those sorts of things may be better than trying to say, let's go see your local psychoanalyst or whatever.
Yeah, where they're going to be less likely to follow through on that.
A lot of it's a focus, too, on getting hooked back in. It's relationships that are going to heal no matter where we are in any frame of our lifetime. And that's what gets lost, is having those primary relationships around us. And if you talk to...
In this mobile society, I've got 3 sons. One's in Texas, one's in Arlington, Virginia, up there. I only have one that's here. Lucky I have that one. But, you know, the society is just tremendously mobile. You don't have the same, they don't have the support systems that they need, and we don't either. So, you know, it's,
You don't have the porches anymore.
That's right.
and we don't have porches.
People
That's
taking walks
another
in
way
the
to put it.
neighborhood waving at you, getting to know your name.
That's true.
I do want to make a point here, and that is that it is a myth that somehow older adults are abandoned by their adult children. Adult children, even though they're far away, maintain reasonable contact with their parents, and they try to do everything they can to help them out. So from my point of view, you should always try to enlist the help of the children or the grandchildren to assist with this, and take it almost as a truth that they're trying to do everything they can to assist their loved one. For example, we haven't talked about dementia and Alzheimer's disease.
Oh, that was going to be my next one, which was how do you not confuse some of these symptoms with dementia? But we're going to take a fast break, and then we'll get back on that in just a moment. Please stay tuned. Thank you.
Patty, let me be honest with you. Won't filing for Social Security benefits online be confusing?
George, it's simple and easy, and you can do it in your pajamas from the comfort of your own home.
Oh, my.
You've navigated through asteroid belts, right?
Oh, sure, plenty of times.
Well, compared to that, navigating socialsecurity.gov is a snap.
Really?
It's so easy. Even Kirk could do it.
Getting health information is a nightmare.
It's all in how you look at it. To you, it's a pile of books and reading until your eyes drop out. But to me, I go straight to NIHseniorhealth.gov, click on what I want, and boom, there it is.
NIHseniorhealth.gov, the medical website created with older adults in mind by the National Institutes of Health.
Getting health information at our age is tough.
Yeah, it's all how you look at it. To you, it's a pile of books and reading till your eyes drop out. But me, I go to NIHseniorhealth.gov, click on what I want, and bingo, there it is.
Well, thanks for the tip.
NIHseniorhealth.gov. It's easy to use. You can make the text bigger, make the contrast better, even make it talk to you. If only everything else out there were senior friendly. NIHseniorhealth.gov, built with you in mind.
Hey, how's it going?
Sir, are you okay?
What? Oh, this? It's probably nothing. I'm sure it'll go away.
Go away? But, sir, that can't be good.
No, it's cool, really.
Do you want a napkin or something?
Everything's fine. Thanks.
You wouldn't ignore this. So why ignore the signs of a stroke? At the first warning signs, call 911 immediately, because time lost is brain lost.
Welcome back to Happy and Healthy. We're talking today about identifying mental health issues in the senior and older adult population. And I'm Louise Thompson. I'm Executive Director at Tampa Bay Community Network. And with me are Leslie Killey, who is the Director of Tampa of Trauma Recovery Services for the Crisis Center at Tampa Bay, and Vic Molinari, who is a professor at USF School of Aging, and Dave Kershaw, who's a PhD Director of the Acute Care Services at Northside Mental Health. Before the break, we had this great question about how do you know the difference between depression and dementia signs, because some of those things are similar, are they not? Vic, or who wants to take it?
Yeah, and unfortunately, both of them may have a similar presentation on the surface. You know, both of them may be associated with cognitive problems, with memory problems. Both of them may be associated with motivational loss, you know, lack of initiation. Both of them may be associated with kind of personality changes. But of course, the implications are very different. Depression is imminently treatable. With dementia, actually about 20% of all dementias are reversible. So it's not necessarily an Alzheimer's type of dementia that's going to have a progressive, deteriorating course. So kind of figuring out what's going on is really, really important. And you have to have a medical workup, unfortunately.
So this goes back to what Vic said. Get to the doctor
absolutely.
first. Get to the doctor.
B12 deficiencies, metabolic disturbances, those can create cognitive problems. If it's a depression, then a medical treatment for the depression with antidepressants, but also some of the social environmental things that we're talking about. So really kind of getting a handle on what's going on, and it may even become more complex than depression or dementia. Sometimes it could be that there's both, and they're intermingled. So someone who is beginning to become demented and is recognizing that that's happening is going to become depressed because of the associated loss of all sorts of things, functioning and things that they value and the possible course. So it's really difficult, but what I think what Vic and Leslie are both saying is that you have to have people involved. That includes the primary care physician, the family. You can't go to the primary care physician and just have that physician talk to the patient. They must talk to the family. They have to talk to someone to get that complete history. What's going on? How long has it been going on for? What do you see? And so really everyone has to become involved. And that's scary to have your life scrutinized like that.
I think this is going to have to be a tremendous lesson to the doctors. I remember when I became concerned about my own mother, I called her doctor and said, could you please test her or do whatever's necessary to find out what's going on, and she's forgetting a lot of things, and I'm worried about her. And he said, you can't talk to me about her. I have a confidential relationship with the patient, and blah, blah. And I said, and who the heck am I going to talk to? You got to do this. Just listen to me. I'm telling you to do this and whatever. Of course, she was pretty ticked when she came out of the doctor's office and they asked her who President of the United States was. She was really mad because she remembered one a couple of terms ago and thought that should count. I remembered Reagan. Why not? I mean, what the heck? But anyway, I found it very disconcerting that I couldn't get his assistance. I mean, what do you need to do if you get a block like that? I mean, of course, I am a New Yorker, so I pursued it. I pushed. But other people don't do that, and they don't push so hard, and I'm just worried about that.
I think a lot of the steps that we need to take as family members, and that's if our elders are going to trust us, and that's to get a power of attorney. And if not, then go to that physician and go with your family member if you can. Go to the doctor appointment with them and sign a release of information. And if your family member does not want that to occur, we as professionals can listen. We just can't even confirm that someone is a client. But I know that we can listen to what you have to say.
But the power of attorney idea is a good one, because then you have a lot more leverage.
If your family member will allow you to.
Right. One of the other hats that I wear is to do capacity evaluations for the court. And unfortunately, if they're not willing, you have to go that route, and then kind of a guardianship is forced on the unwilling older person who doesn't feel like they need to have someone help them make those life decisions. Always going to be ideal to engage the person that you're working with and engage them in a collaborative kind of help seeking, where it's like, hey, I'm seeing this, let's just try this. I'm concerned, you're concerned. You don't want to kind of undermine the trust that you may have by kind of sneaking around and talking to a physician if you can avoid it. We want people to be as independent as possible. And unfortunately, with something like dementia, it does get to the point where you may have to become more involved against their will.
You mentioned earlier that white males over the age of 75 were more at risk for suicide. Are there other groups that are more at risk for the depression? Like, for example, I just recently heard about veterans. Is that?
Well, people with post-traumatic stress disorder certainly are more at risk for the clinical syndrome of depression, as are people who have been abused and those who have had some traumatic experiences in their lives. My sense is that whether or not you fall into a particular group, it's these symptoms that we've been talking about that are so important in terms of getting the person to get help. Like, for example, one research finding is that the people least at risk for suicide are older, Black, females.
Yep. African American
You
females.
know, but
At least at risk.
They're least at risk, but if you talk with a woman who is saying that they're feeling real bad, they've been feeling like this for a couple of months, they're thinking about death and dying a lot.
And don't dismiss it just because I'm black or
they
whatever.
fit into a certain group.
Yeah, it really gets to the difference between historical and
I'm just
demographic
saying,
risk
though,
factors and clinical risk factors. And, you know, all the data in the world that suggests that, okay, a 75-year-old white male who's got a terminal disease, who knows how to use a firearm, who has a history of traumatic, you know, if that person looks like they're doing well and isn't depressed, then that person has risk factors, but they're not at risk for that event. And
okay, but you pay more attention
to
it.
it. Yes,
absolutely.
And so, some of the things you're saying, I keep thinking of Hillary Clinton, I'm sorry, but it takes a village, and some of the things, and she was talking about children, and but you know, it's all of us. I think that's what you're all saying. It's just not gonna, we're not gonna be able to solve some of these issues unless all of us are pretty attentive to what's going on around us. And we're too busy.
We didn't really talk about caregiver stress and strain too.
Yeah,
kind of
I'd like to do that, and I want to talk about the myths of aging, that all of us are under those wrong things. Those wrong thinking things. Leslie, you want to talk about any of that? I think you brought that up earlier.
I just think that we're missing out on the richness of the people that are older right now, the baby boomer generation, have had more change in their life than any other generation will see, in terms of the advent of technology, the advent of living your life behind a television, which has created more isolation, I believe, also. But if we take the time, as caregivers, as physicians, as whatever role we're in, to listen, and listen behind the words, and hear the story. That's where the connection is, and that's the best way we remember as people, whether we've got traumatic experiences in our life, and by the time we're this age, we have them. But it's being able to have someone that will hear your story and share that with others, and that's how we share the richness of who we are. That, I think, is a piece of also what gets missing. When we have people come in to see us in trauma recovery services, they tell us frequently that that's the first time anybody's ever just listened and not tried to quantify them or diagnose them or put them in a box, but just hear what they have to say about their life.
Are you finding that in studies too?
Well, you know, my sense is that the research strongly supports what Leslie says. One of the things that is a very clear message from the research is that interdisciplinary teams, where different professionals get together and talk about this older individual and can share information so that there's no duplication as far as medications, but also share their life history, the patient does much better rather than working with an isolated mental health professional or a physician. So very, very clearly, you know, medications are part of the solution, but the talking and getting to know the person is just as important. You know.
Myths.
Oh,
give me some. Something I can send to my children, for example.
That older people are dependent and inflexible in their thinking.
Ah, okay, there's one. We are not.
You absolutely are not.
Okay.
That elder people are not sexual.
Absolutely.
We are, yep.
That older people don't gamble or have problems with gambling. And we talked earlier about substance abuse. And those are negative things, but
one myth that I'm really particularly concerned about is this idea, as we talked about, that somehow adult children may just kind of abandon their loved ones, their parents, when in fact, as we talked about with caregivers, the burden on caregivers is tremendous. And oftentimes, children and grandchildren or spouses, if they're trying to take care of someone with dementia and keep them out of an institutional setting, is very great. You have emotional burden. They frequently get depressed. Socially, they become isolated. Financially, they have to pay a lot of money to get the proper workups. So there's a constellation of things that really increase the burden. And the idea that when this caregiver, this child comes before you, you should always assume that they're doing a lot of what they need to do and they're really doing the best they can, as opposed to they can't wait to throw granny in the nursing home and lock the door and throw away the key.
Another myth.
Yes.
Okay. Do we have more?
Another myth that we talked about a little bit was relating to this idea that, and we've been talking about this in a certain sense, that all older adults are depressed. That is not the case. Just like all older adults are not senile, older adults in general sort of negotiate the losses that we've been talking about much better than one would expect, and they accrue wisdom and that really can help them adjust to these difficult life circumstances. And so that the other thing regarding dementia is that although everybody, I think there was a study today that indicated even after the age of 45, people's memories to a certain extent are declining, probably even earlier than that. The fact is that most older adults manage pretty well in terms of it doesn't affect their day-to-day functioning. And one other thing with this is that when you hear an older person telling their story, it doesn't mean that they're senile. It may mean that they want to be affirmed as a person and let you know that they were once a vibrant athlete or ballerina and manage their life very well without the disabilities that they now show. And you should honor that, and affirm them as individuals.
That seems like such an important thing. And I'm just recollecting that I years ago had a near fatal car crash and was hospitalized for 2 months and became terrifically depressed about it. And I remember saying to a nurse who walked in, do you know I was a very viable human? I said those exact words. I was a viable human being just a week ago. I serve on 12 different nonprofit boards. I really run a company and everything, and I just wanted her to know that this sack of potatoes over here that can't get out of a rotation bed is really okay, you know what I mean? Could you please know this? So what you're saying makes so much sense to me, that when you're down and out, you want people to affirm who you were and that you can maybe get back there again sometime, or at least carry that reputation with you that you might have had. That's a really interesting thing. We should probably hit the caregivers a little bit more on what they need to do, because we've talked about seniors and that they have your services available to them, that they can make these calls, that they can have reassurance, that they can go to Northside and MHC, and there's all these, they can go to their doctor and they can do all this stuff. But you mentioned the caregiver who's under this enormous pressure, and also financial, I'm assuming, because if you tried to go to work, and care for a parent, you may have to hire someone, and that may not be covered, and so forth. And so what should they do? I mean, can we address that for a minute?
Well, sure. Caregivers really do need to take care of themselves. And one of the things that you tell a caregiver is if they don't take care of themselves, their loved one is not going to be taken care of. So frequently what you want to do is make referrals to support groups to assist them with really talking with other people who are in the same boat. Let's just say that the spouse is dealing with their husband who is declining before their eyes and now doesn't recognize them. It's a very difficult thing.
That's got to be awful.
Yeah, and to talk with other people who have been through that can be quite healing. The other thing would be is that they have to enlist help from others, and they should not consider that being selfish. They should consider it in the long term. That's what they have to do for the well-being of their loved one.
You have some programs over at Northside or Crisis Center for support?
Well, we have more general peer support groups that aren't necessarily designed specifically for caregivers. But kind of to echo what Vic was saying, I think that it is very important to take care of yourself as a caregiver. I'm trying to think of a kind of an ingenious arrangement that two caregivers that I know of where they would make an arrangement where one of them would care for both of the elderly persons during the day, and that would give the one family member kind of time off. And you can't be consumed by guilt or by concern that you have to control everything. You have to let some of that go, and you have to ask for help. And I think the peer support groups, the caregiver support groups are really important, because those are folks who are walking in the same shoes that you're walking in.
Psychologists have actually also developed certain techniques to manage some of the behavior problems that are often attendant upon people with dementia or Alzheimer's disease. So consultation with a mental health professional can be quite helpful in terms of when somebody, let's say, starts lashing out and fighting or whatever, there may be ways of managing that problem behaviorally that doesn't necessarily involve psychiatric medication.
And I think all of it becomes a dance. It becomes a dance for the caregiver, and it becomes a dance for the person that's going through this process of facing losses. And my 90-year-old says it pretty well. He's a 3-war combat vet, POW, and I take care of him in the home. And he says that he feels like he's stronger now than when he was viable. Because he's stronger now because he's had to live with pain, and he's had to live with losing people that he loves, and yet he's found a way to still carve out meeting. And everyone that meets him go, he's so social and he's so engaging, but I think what it is he has found his will, and he has found a way to engage. But he says it takes more strength now to live than when he was 40 and 50 years of age.
Yeah, there's remarkable resilience.
It's incredible.
In older Americans,
yeah,
older adults in general.
That's an interesting commentary, don't you think? Yeah. We're gonna run out of time in a little while, and I want to make sure that each of you has an opportunity to give me a couple of more minutes on something I didn't ask you that you really think is important for folks to know, either about any of these mental health issues or about your own agency or what you're doing or what they should be looking at. I'd leave it open to each of you. You want to start off, Leslie?
Do not see it as an issue, and do not see feeling sad, mad, or angry as a problem. Keep relationships in your life, all of us, at every age level. Have friends that are children. Have friends that are 20-somethings. Have friends that are of your own age. And trust your doctor. And if you have questions, please don't feel afraid to ask. For us, call 211 any time of the day or night, and we'll be there. If you would like further support, it'll be available through the Elderly Reassurance Line. We have trauma recovery services for counseling also. And a lot of times, please know that when we have you come in, we'll work with the whole family. This isn't about you coming in alone. I think the toughest thing in the world is to sometimes look in the mirror with the person we brush our teeth with in the morning and go, gee, I can't do this by myself anymore. If you come to that one morning, pick up the phone and talk to someone, build that relationship, and you'll find a quicker path to healing and finding a way to define your life.
Both your agencies are sources of referrals to other groups and agencies in town if needed, correct? Okay,
absolutely.
So it might be one particular thing or another that they need, and you'll help them figure out who it is, or you'll figure it out for them when they don't really perhaps know where should I go. So if they call 211 or they call Northside, they'll find out.
And that's kind of the great thing about the mobile crisis team, is that there really is not a wrong door by using them. You know, it's a door, and then through that door, they can figure out what's really the best match for what you want. It's not what they want. And I think my kind of take-home message is that people recover from mental illness, whether they're kids, adults, or older adults. And oftentimes, they don't recover unless there's some sort of a strong healing relationship that's involved. It might be just a PCP, it might be a specialized team of people, it might be a peer, it might be a family member, but there's reason for hope. But oftentimes in older adults, someone else might have to take the first step. And I encourage everyone to speak up, to be the voice of the individual who may not have their voice or have lost their voice. So if that means that you don't feel like the doctor is really listening to that person, I think you need to give that physician some feedback. Okay, you have a choice. That's kind of my take-home message.
And I know you said ask your physician questions, but I've been hearing some commercial lately about that. Write down the question, because I don't know what it's a commercial for, but anyway, I remember that I just heard it yesterday. And you know, it's so true, because if you don't write it down, you've thought about it. Well, I have this appointment, I'll go ask my doctor X, Y, or Z, but then you don't do it because you've forgotten. By the time they start talking to you about some other thing, you're going down another road. And maybe I'm the only one with ADHD, but I'm sure I'm not.
No, you're not.
And so they took me down a totally different road. I forgot, get in the car, go, oh, you know, I forgot to ask, you know, about some symptom or another, right?
Allowing people to tell their story is a really powerful thing, and it's
I
one
think
thing that
that's
we
a
do at
great
Northside.
thing.
It's not you coming in and let's generate a billable code for you or a checklist. Let's listen. Tell me what your story is, and you're gonna pick up what hopefully you're going to develop as a collaborative treatment plan based on what they say, but also on what they don't say. And so, you know, that's just an important step. You got to engage people. You got to engage them at what they want, not what you want.
It's a good time too. I did a show it was a few years ago with a woman who called herself a personal historian, and what she encouraged people to do themselves, or she would help them with it, is to write their story as their sort of, if you're going to have a will with items you're going to give away, why don't you make a story, which I think used to be done in days of old or something, and make the story and then pass that on about your life or what have you, so people, you know, it may not be this child who's interested in it, but it could be your grandchild who gets interested in it, or some, you know, one of your children anyway. So
I think that's a great idea.
That's a good idea, isn't it? Winding up.
Yeah, well,
Dr. Vic from New York.
My thought is that the aging of our population is something that we're all going to be dealing with our parents, our grandparents, our aunts, or uncles. It's coming, so we need to prepare ourselves for that. One way would be is that my sense is that we need to put more money into education, particularly with gerontology programs. And one very sad finding is that a lot of the geriatric medicine residencies actually are not being filled because of the reimbursement kinds of mechanisms in place that make it difficult for geriatricians to make a good living, surprisingly. So this is this is in the United States, yes, very clearly, And
it's crazy.
You would think, yes.
There is no geriatric psychiatry unit in any hospital in the Tampa Bay area. And the last thing you want to do with an older adult who needs to be hospitalized is to have a patient mix on a unit that has a lot of younger, active individuals who may have problems that are very different than that older adult. These units are a scary place anyway, and so I think that's a great commentary on what we value as being important, what gets funded.
Yes.
Did you want to add to that?
Just one other thing that, as far as reimbursement mechanisms, I belong to a group called the Psychologists in Long-Term Care, but this probably relates to social workers, medical people as well, is that there's this big budget fight, as we know right now, regarding Medicaid, Medicare reimbursements. And just to note that, from my perspective, when you reimburse health professionals well, you will go ahead and get more mental health professionals who really know what they're doing, who are trained in geriatrics, who can address these very complicated issues that we've been talking about.
Are there specializations in geriatric psychology?
Yes, the geropsychology.
And so there are schools of, USF does this too, or no? Not medical. I mean, that would be a medical psych.
In psychology departments across the country, there's unfortunately only about 10 to 15 programs in geropsychology, not nearly enough to meet the mental health need. We do better at the internship and postdoctoral levels, but not at the graduate level where you're going to get the experts who are really groomed to further the knowledge. And I think social work, nursing do a little bit better with this, but we're way behind the curve, all the disciplines are, in terms of really making sure that all the older adults are served properly.
My last question is to the, maybe you can address this to the viewer. What can we do about this reimbursement problem? So, because we're all aging. I mean, if we're lucky, we'll all be continuing to age. So whether you're watching this and you're 40, you still got to worry about it, right? Because hopefully you will have to worry about it. So you mentioned this reimbursement problem. What can we do? Is there anything? Call your...
Yeah, I mean, my sense is that there's not a week that goes by that I don't get some message from a political listserv that I'm on regarding reimbursement for psychologists, and I'm sure it's true for social workers, nurses, other mental health professionals are running scared in the private world because the reimbursement rates are so low. And unfortunately, what that means is that some people may get out of working with older adults and work with in fields that are more lucrative. And
so
I find
here's
that
another
problem.
one, folks, where you have to get on the phone, call your senator and your representative and congressman and everybody and tell them to get going on this, because it's important that we show caring for the older adults. I want to thank all of you for coming here. I hope you come back again, because you have so many wonderful things to convey to people, and we're totally appreciative of that. And thank you to our viewers for tuning in, and we'll see you next time.
Getting health information is a nightmare.
It's all in how you look at it. To you, it's a pile of books and reading until your eyes drop out. But to me, I go straight to NIHSeniorHealth.gov, click on what I want, and boom, there it is.
NIHSeniorHealth.gov, the medical website created with older adults in mind by the National Institutes of Health.
Getting health information at our age is tough.
Yeah, it's all how you look at it. To you, it's a pile of books and reading till your eyes drop out. But me, I go to NIHSeniorHealth.gov, click on what I want, and bingo, there it is.
Well, thanks for the tip.
NIHSeniorHealth.gov. It's easy to use. You can make the text bigger, make the contrast better, even make it talk to you. If only everything else out there were senior friendly. NIHSeniorHealth.gov, built with you in mind.
George, it's a great deal. Only used a couple of times, and it gets great parsecs for very little dilithium crystals.
Well, I appreciate the offer, but what I really need is information about Social Security. How do I find out what my monthly payment will be?
Online.
How about if I just want Medicare?
Online.
Oh my. We'll boldly go to socialsecurity.gov.
Let's go kick the tires.
哦，先生你好，歡迎光臨，等等先。誒，唔該晒。
Brandon.